Hello, guys. So this is stuff I learned from Endo. So the first thing here is so the heat in the summer increases the TSH. So this is just a reminder. We see a lot of TFTs being abnormal. So the heat from the sun actually just degrades the medication or whatnot, and so patients don't get enough, and we see an increase in TSH because of the heat. And these patients are getting 30 days, 90-day supplies. As it's on their patio, on their porch from deliveries, and so anyway, it affects the thyroid medication. The other thing is, it's just a reminder about pregnancy. So one of these things, is, again, so vomiting. I have about 2-3 hours after taking the medication in pregnancy, just take another dose. So we probably, I don't really tell my patients that I forget. Say, hey, if you throw up, but then if you took the medicine a couple hours ago, take another one. It's okay. The urgency of pregnancy and taking the higher dose ASAP. So it's like an emergency. It's like almost like DK. I mean, it's one of those things that as soon as you find out somebody's pregnant, increase the dose. And so get the blood work done, and then and see them right away. So this is a very urgent matter. So we should probably retrain our staff on the urgency of pregnancy and having these people come in, making room for them in our slots so that they get seen. So the other thing on pregnancy is, TSH over 4. This one speaker was like, you should probably treat these guys, especially with the positive antibodies, and then if they do have positive antibodies, consider treatment over 2.5. Okay, so again, the take-home message is, really treat hypothyroidism in pregnancy. Treat it early, treat it urgently, and just have a low threshold for treatment. And especially because remember, the first 3 months of pregnancy, the baby doesn't make any thyroid hormone, and that's where we're really focused on. So hyperemesis in pregnancy, TSH goes down, and and then the free T4 goes up. So just keep that in mind. So if patients coming in throwing up and TSH goes down, it's okay. It's just more of a sick euthyroid syndrome. But keep in mind the T4 goes up as well. So triglycerides, not focusing on lipids, triglycerides go down 50% every 24-hour fasting. So it was interesting. It was this good physiology update. We put patients in because of pancreatitis. They have, triglycerides of 2,000-3,000. And every 24-hour fasting, it goes down 50%. So they stay a couple of days and it goes down to normal. Then we discharge them, right? So so you can do this in the clinic as well. So if somebody comes in with triglycerides of over 1,000, again, the urgency of it, so we need to tell patients, hey, your triglycerides are over 1,000. I need you to fast for 24 hours. And we should recheck these triglycerides, in a day or two, and it will go down 50%. Okay. So again, if we see these patients in the clinic with triglycerides over 1,000 or even 800-900, and, again, it's one of those things, if you want to, teach the patients that, what, it's really high, get them down, and after fasting 24 hours, let's recheck it. Familial hypercholesteremia, if they really truly have this, we're kind of obligated to check the first degree relatives. Okay, so if you have patients that have FH, okay, we need to test their siblings and test their kids. Okay. So premature heart disease. So what is premature heart disease? And it's really, a cardiac event or stroke or PVD or, PAD or anything before the age of 60. So a family history of any issue is before 60. My dad had a heart attack at age 50, 55. Well, that's premature heart disease. This is a website. It's pretty interesting. I just I checked this out. It's endotext.org, and when you go there, click on at the top clinical guidelines. So they make you register, and that you can pay to download stuff and all this stuff, but you don't have to do that. It's just go here and it's go to clinical guidelines at the top, and it have all the guidelines, and it takes you to ACE, National Lipid Association, from adrenals to thyroid to everything. So it's kind of a good summary of the latest guidelines. So it's actually pretty neat. So it's articles, you got to read through it, but it's really organized. So some of you, we talked about this at lunch last week. So check LP little a at least once on everyone. So there's some, lipidologists like, well, I don't check it on everyone, and then others are like, well, I do check it on once on everyone, just as a baseline type thing. So once it's high, it's like thyroid antibodies; it's always going to be high. So the question is, what are we going to do with this? And so what you do with LP little a, if it's high, it's like smoking. Why do we ask if people smoke? Well, so if they're smokers, we're going to be very aggressive in these patients, right? We're going to be even tighter on their blood pressure, cholesterol, diabetes, etc. So LP little a, if it's high, they're at a higher risk of complications. They're at a higher risk of heart disease, higher risk of stroke. So these patients, we don't need to be messing around and saying, no, I don't want to hear it. We need to treat you aggressively. So the guys that you're, considering statin or no and things like that, and and they're reluctant, etc. So this is very, very important and helps convince the patient as well as you to be more aggressive. So, there's not much that lowers LP little a, nothing directly, but niacin, PCSK9, and estrogen lowered about 20-30%. So keep that in mind. So we can use those if we really needed to. Also ApoB, ApoB is everything bad. So, when do we check ApoB? So we don't really check ApoB because we just check the LDL and we calculate non-HDL and in some situations, and but if the triglycerides are under 500, if they're like over 200, it'll mess up the LDL and the non-HDL calculations. So so this is a good way to check their status of their LDL if their triglycerides are under 500. If they're over 500, then treat the triglycerides and then look at the LDL later.